Yes. So this is our recording. Um, so we'll introduce the first speaker. I'll hand over to Chris again. Chris, you're mute. Mute.
Perfect. Great. Yes. If, as Charlene said, you can put on your cameras, that'd be great. I know some of you can't, but it's always good to see faces whenever people are presenting. Um, so the first speaker is Dr. Suzy Connor. She's an emergency medicine consultant based down in Derriford Hospital in Plymouth. Um, Susie and I spent some time in Kenya recently, where we spent some time in Meru Hospital. And she's going to provide us with a case study today via colleague, I think a colleague's experience as well as yours, Susie, and you can clarify that for me. But it's a trauma-based case study. So I'll share screen and I'll hand it over to you.
Oh, thanks, Chris, for that intro. Are you okay to do the slides? Is that all right?
Yeah, that's absolutely fine.
So,
You have to see that, is that okay?
Yeah, that all looks good. Thank you. So my name's Susie. I'm an ED consultant down in Plymouth. It's actually sunny Plymouth today, sunny but cold. Nice to see some familiar faces on there. And this is just hopefully a run through a case. And so I was lucky enough to spend some time in Meru Hospital. I don't know if we've got any of our Meru colleagues on today. I'll be spying you on the camera if so. And then my colleague Sally and Annette then were lucky enough to spend some time out there in September. So I was out in June, and Sally and Annette went out in September.
Kwani huku hiyo place mse unatuma alafu uingi ashakutumianza
Oh, I think Dennis, you're on. Yeah, put Isa. That's it. Fab. So we thought this would be a really thanks for the opportunity for talking, and hopefully this is a case that my colleague Sally, she's actually working at the moment, saw a few months ago. But hopefully the learning points are pretty transferable, and it's something we can. I'm sure you guys have all had experience on, and it's just getting that, speaking up in those times where you need to speak up, giving you the confidence to speak up when you need to. So please do ask loads of questions, put your hands up during if you've got anything, or put questions in the chat and I'll try and answer them at the end. That would be great to get a bit of interaction. So just to let you know where we are, on the next slide. Thanks, Chris. I'll just give you a wee bit of where we are. So that map, for those of you not in the UK at the moment, or based out in Kenya, so you can see that wee red dot on the top left and the picture on the left. So we're down in the southwest of England, and then in that slightly more zoomed in map, we are the circle towards the left, so the down towards the toe, and I've got some Cornwall colleagues on there. They're even further down. But yeah, so we're kind of I'm in Plymouth Hospital, which is so our nearest, I guess, big city with an airport is about 2.5 hours away, which is up in Bristol. That's where Chris is. And so we're about 2.5 hours by road from there. It's quite a biggish city, so we've got a population of just under 300,000. It's a mixture of, we've got a big military naval base down here. As you can see, we're right on the coast. There's a few factories, service industries, education. There's 3 universities. But outside our city, the rest of Devon and Cornwall is fairly rural. As you can see, we've got quite a lot of coastline nearby, so we get a lot of our trauma is quite seasonal. So our usual trauma is we get loads of road traffic accidents. And then in the summer months, when all the kids start going out and doing crazy stuff, jumping off cliffs, etc., we get a lot more of that kind of trauma over the summer months. But our main trauma is usually kind of road traffic accidents, high risk activities over the summer months, and then a huge lot of our work is from our quite elderly population who fall often from standing. So we're a major trauma centre for adult patients, and we're a trauma unit for our paediatric patients. So our really sick paediatric trauma patients, you might come to us initially, but then they'll be transferred up to Bristol, either by road or by air. So we cover quite a big area, and we cover a population, I guess, at our hospital of about 500,000 and a bit more over the summer. So that's kind of where we are. On the next slide, I'll just show you our hospital. And I don't know where Sally got this picture from, because it's not usually quite so quiet in our car park. I think today we've probably got about 30 ambulances waiting out there in that in the car park there. So we see probably about 300,000 patients maybe not quite so much, so maybe about 200,000 patients a year. We've got all adult specialties, but yeah, as I say, our really sick kids, we don't have a paediatric intensive care unit, so our really sick kids have to travel by road. Within our department, again, that waiting room is looking nice and empty there. It's not often looking like that. We have got like a 7-bay resus area. We've got an ambulatory majors area and a majors trolley area with about 35 trolleys. And the hospital's got about 1,000 beds, most of which are full most of the time. So that's where I work, and that hopefully just gives you a wee bit of insight into where we are and down in the southwest of England. And we've got a separate paediatric area as well, which is quite nice. So if we just go on to the next slide. So the case I'm going to talk about is, I guess, not too unusual. It was in the afternoon. It was a 62-year-old male brought in by the police. So he was actually arrested. So he's out walking in Plymouth, naked, trying to get into cars, basically. And he was, showing some quite aggressive behaviour, trying to rip the doors off of cars, naked. He'd been noticed that he was banging his head against the cars as well. And once he got into the police car, he'd been, banging his head against the police car. He was complaining of a bit of chest pain. So once our patients, they come to the front desk, they book in, and usually if they've come in by car or by police car, they're put into what our ambulatory majors area, and they wait to be triaged. And they're all meant to be triaged within 15 minutes. Again, we struggle to achieve that. And when he was brought into the triage room, so our nurse sits with the patients, was quite hard to obtain a medical history from him. He wasn't really making much sense. He was denying having any alcohol or any drugs on board. We found that, you know, his current address was at the Shekinah Mission, and that's one of our homeless patient hostels. And he said that he was looking, we asked him why he was trying to break into the cars, and he said that he was looking for the transit van that he was living in. And there was nothing on the GP records and no recurrent repeat prescriptions. So he was, you know, it was quite a busy time of the afternoon. They were his observations, as you can see. So SAT's 94%, maybe a wee bit low. Someone who's 62. You know, blood pressure looks okay. A wee bit tachycardic. He was said to be alert, no temperature. And so he was just not really, you know, it wasn't really clear. But he was given a triage category of 3 because he had chest pain. And he was put in a cubicle in our ambulatory majors area, which wasn't really, it's not a well looked after area. You know, you can just be sitting in there for quite a long time, waiting for sometimes, you know, kind of 6 to 8 hours for assessment by a doctor in that area. I don't know, anybody want to jump in and say where a patient like that might be looked after in your hospital with police?
Feel free to use the chat as well to answer any of these questions if you're more comfortable doing that as well, everyone.
I mean, it's quite hard, these patients who are, you know, you can't really put them in the waiting room. They're with like a couple of police officers. They're naked, so it's not ideal.
Kind of depends on your space, doesn't it? We've just, in Truro, we've just created a part of the waiting room that's actually got nursing observation, which sounds a bit ridiculous, but we've cordoned off half the waiting room, and that's kind of an observation part of the waiting room. So this week we do that. But before, he might have just been in the waiting room with the police.
Yeah, and I think as our pressure for space really increases year on year, it's really hard, isn't it, with these patients that aren't quite fitting into, you know, you're not super sick, you're not quite sure what's going on. It could be anything really. And, you know, I think actually putting him in a side room was, you know, maybe a reasonable plan at that point. So based on those observations, so he's given a triage category of 3, which, you know, our category 1 is just a reminder, you know, that's seen straight away. That's, you know, kind of cardiac arrest, anaphylaxis. Triage category 2 is, I think the RChem rules so the Royal College rules say that guidelines advocate triage category 2 seen, I think it's within 15 minutes, 15 to 20 minutes. And again, so but triage category 3 in our hospital, you know, you could be waiting a good kind of 4 to 8 hours. A chest x-ray was requested. He had some bloods requested, but not yet obtained. An ECG was done, and he had paracetamol and codeine prescribed by the doctor who was kind of overseeing the area, but they hadn't actually seen the patient, but they were given some analgesia. So if we move on, so this is 2 hours later. And that's his observations. He was becoming more agitated and difficult to manage. Somebody had asked if one of the doctors could prescribe him some benzodiazepines, so some lorazepam, because it was thought he might be withdrawing or something. And I think because he was in a side room, he didn't have an IV line, and it wasn't really safe to give him any IV benzodiazepines. That wasn't done. And it was thought that he wasn't that safe, even though he was with the police. It thought he was becoming unsafe in that area. So I think if you had a patient like that, is there anything, I don't know, you guys might think with OBS like that becoming more agitated, where would you move him? Would you keep him there? What were any thoughts? So what we did do, he was moved into our resuscitation area because it was noted. So the healthcare assistant who picked up on his OBS that actually, was now on 15 litres, sat at, and that's quite a big jump, to be suddenly on 15 litres. He'd become a bit more tachycardic, and they were really worried about him. So we moved him into resus. And it was noticed. So in our resus area, we've got a lot more, there was there was one registrar and there was one, so an emergency medicine registrar, and there was an emergency medicine junior doctor, both working in resus. And when they came in, and that was his OBS, so they saw his OBS, he was needing 15 litres of oxygen. He was denying any trauma, and he still said he was trying to get into the van that he was living in, but they noticed he was covered in bruises, and that hadn't been picked up earlier. They found that he was confused, and they got a bit more of an alcohol history, a background history. So he was quite a heavy drinker, and he was drinking about 1 litre of whiskey a day, but he hadn't had any for a couple of weeks. So if you just move on to next slide there, Chris, you can gives a wee bit more of the story. So in the resus room, when they got a full examination, they saw that he had palpable surgical emphysema throughout his torso, over his neck and his upper limbs. So you could actually feel that crackle of the surgical emphysema, and he had reduced air entry on the right. He had SATs of 98, but that was on 15 litres, sorry, not room air. He was tachycardic. He had a good radial pulse. He had bruising to the left forehead, and his abdomen was soft and non-tender. His pelvis looked okay. No long bone deformities. So you've got two doctors there, one quite, experienced doctor, one more junior, and also a very experienced emergency department work, who actually works in a different area now, different department, but she'd come back to keep her skills up. The two doctors are working together, taking a history, trying to get a line in, noticing the extensive surgical emphysema. And then the senior ED doctor recommends a CT trauma in light of the head injury and the chest findings. And then just at that time, when they're discussing the plan, getting a CT, thinking about organising a trauma CT, another patient comes in who's very unwell and with an unrecordable blood pressure. So Dr. A, the more senior doctor, leaves at that point, leaving his colleague to complete the assessment, write the notes and organise the investigation. And that's where the patient becomes more sick and more sick. So is there anything, just given that examination and the history, that is going through your minds, anything that you feel that needs doing at that point?
Truro team wonder if he's got a tension pneumothorax.
Yeah, that's a fair point, Truro team, and I'm glad you said that. Yeah, because I would agree. And what would your team like to do? What do you think's the thing that needs doing right now? And what would you do if that was you? If that was you as the junior, as the emergency department medical officer or SHO? What do you think? What would you do?
So can we just check? We think he's in resus already.
Yeah,
so
he's in resus. Yeah,
an area, a suitable area. But if we think he's deteriorating fast, then he might need a decompression of his chest, unless you can get some quick imaging. But if you're not going to get that quickly, then clinically we might decompress the side of his chest that we're worried about.
Yeah, so he did have a chest X-ray done earlier, and no one had looked at it. But you're right, and
we'll have a look at that then.
Yeah, no, thanks. That's good. Is it? I can see you, Anna, so I'm picking on you and the team Truro, but feel free for anyone else out there just to jump in if you want to. Otherwise, I'm going to keep picking on the Truro team. So this guy's looking absolutely rubbish. He's he's now he's not even talk, he's hardly able to talk. He just looks absolutely clapped out. He's covered in this surgical emphysema, and you're on your own as the medical officer. So Team Truro, you're gonna decompress, yeah.
Yeah, and we were just saying he'd probably need a finger thoracostomy rather than a needle if he's blown up like Michelin Man with his with his surgical emphysema too.
Yeah, I think that's a really good call, and we definitely talked about that. I don't know if there's any of the Meru team on there that were at the on the tech course back in June, because we talked about this. So hopefully. This is really relevant, and this is why we go through all, we were simming it back then, and we had our nice rack of ribs that we practice this on. So yeah, and we've talked about we often have this discussion, in our trauma centre about, do you bother, needle decompression? But I think you guys are right. I think, yeah, I would probably go straight in for a thoracostomy with this patient. He looks rubbish. He's got a pneumothorax. And if somebody had looked at the X-ray, I think it's coming up later, but we'll go on to the next slide. Yeah, I mean, this guy was about to arrest. And he looked absolutely terrible. So the medical officer is trying to organise the scan, but he struggled to get through to radiology on the phone. And when he was on the phone, the radiologist wasn't happy to do the scan because there's no actual history of trauma. And in the meantime, the minutes are ticking by. And the patient's getting more and more agitated. Initially shouting and moving around the bed, and then trying to get up, pulling off his monitoring. And the nurses are asking for medication to keep him safe on the bed, and there's no way he's lying still for a CT. So the SHO is getting more and more overloaded with not knowing what to do next. And so asks for help from the senior, who's also in the resus room with another patient, but he's really busy with another patient next door. And he offers some verbal advice to give him some more benzodiazepines or some ketamine to help him get him through the scanner. But they've become really focused on getting this patient to scan because they're task focused and not realizing what else are going down. But meanwhile, the IV access is out because the patients have pulled it out and the patient stats are dropping, and the nurse is worried that the patient's getting more and more unwell, and she tells the doctor that he needs to get some more help. But that doctor has already got a plan in his head that he's discussed it with the senior doctor earlier, and he's task focused in getting this CT booked. And now he can't see what's going on in front of him because he's focused on getting some medication into the patient, and booking a scan and getting the patient through to scan. And nobody feels that they can speak up about what's going on in front of them. So, and just, you know, as demonstrated in the next slide, you know, patient continues to deteriorate. He's becoming more tacky and short of breath, fighting to get off the bed, and then he stops fighting to get off the bed, and he becomes sweaty and grey. And luckily, the nurse, our really experienced nurse, sees that the doctor is struggling and worries that the patient's about to arrest. So, in fact, she's the one that goes out and gets the more senior doctor who's out in the majors area seeing another patient at the time, but recognise that this patient is really sick and needs another set of eyes. So the patient stops talking, and the nurse leaves the resource room to find the consultant in charge of the department to come and give some help. Now, luckily, Sally was the consultant on call, and she's worked with the nurse before and knows she's clinically excellent, and comes in and sees that the nurse is really worried, and her request to attend the patient is time critical. She finds the patient sweaty, pale, gasping for breath, and the patient looks terrified. And the poor doctor doesn't look much better. So with the benefit of a fresh pair of eyes and some bandwidth, because this, you know, the doctor who's just stepped into the room can then recognise that this presentation is likely, as you said, Team Cornwall, that this is likely a tension pneumothorax. And the patient just has that look. You know that look when you walk in and you see them. And I know you've all seen it, and I know my colleagues out in Meru have seen it. The patient just looks absolutely awful, and there's something really bad going on. They feel the surgical emphysema and have a listen. There's not a lot of air entry, but the right side doesn't seem to be moving at all. And then the doctor who was with the patient initially remembers that there's been an x-ray. So they pull that up. And you can see it on the next slide. And that should be coming your way. There you go. So that x-ray was taken nearly an hour previously. So you can see there's lots of surgical emphysema, multiple rib fractures, pneumomediastinum, and likely a right pneumothorax. So yeah, what do you do now? What are you going to do now? You've got that nice you've got it there in front of you. Well, we're going to do what Sally did do was, as you guys suggested earlier. So we gave so the patient had ripped out their IV access, so they had no IV access. He's looking absolutely terrible. We gave him some IM ketamine, 2 milligrams per kilogram, because he'd already had a wee bit of lorazepam on board, and we did a thoracostomy. So incision, blunt dissect down, and then finger him. And then we got ready to intubate him. So if we go to the next slide. Yeah, so just a wee reminder, those of you that were on the tech course, this is what we talked through. Remember that nice triangle of safety. Don't be tempted to go low. Make sure you've got the right side, gloves, clean the skin, make your incision, blunt dissect down with artery forceps or whatever you've got, and then finger through the pleura. Just hold that finger in there for about 10 seconds. And they did get a really nice hiss. Then if you go on to the next slide, we can jump through, see it. They got a nice hiss. And on the next, and then after that, we put them to sleep, in order to safely get him to scan. Now we're really lucky. Our CT scan is maybe only is next door to our emergency department, so the transfer through from our resus room round to CD is pretty quick. On there you can see, oh sorry, I'll just move, oh thanks Chris, we'll just move on to that CT. You can see he's got bilateral pneumothoraces and a big pneumomediastinum, so that's air around the mediastinum. He's got consolidation at the bases, and he ends up having bilateral chest drains and a fairly long stay in intensive care. So I'll just move on to the last slide. So I think we just really wanted to, I thought this is hopefully a good case to chat about. And I don't know if you guys think, is there any, what are the points where this, in the patient's journey, that his injury burden could have been recognised? What factors do you think in this kind of patient, possibly got drugs and alcohol on board? Does that contribute? Do we think, is that to the patient's, detriment of their care? Is there anything, do you think, if this kind of patient had presented to your hospital, where would you have looked after them? And do, in times like this, have there been times where, I don't know, maybe you felt really similar, it's really difficult to speak up? Or what are the things that we can help, maybe learn from each other about helping us speak up? Please do, feel free to chip in, because I know it is sometimes difficult, especially when you are maybe the more junior doctor and you've got an experienced person who's told you to do something, and you've then become really like task focused and must do that. And sometimes you don't see that, the patient deteriorates and actually they just need something else doing. So feel free to pipe in with any ideas that you have got. What are your thoughts on the case? Is that something that, something similar happened to you?
I'll start, Suzy. Thank you very much for sharing your reflections on that case. I think it's really interesting how certain patients, when they present, we do have a diagnostic bias when it comes to what we think they are before they've potentially even opened the mouth and gained a history from them, just maybe even from the triage note or where they're placed in the department. So I think it's first step probably being aware of that bias as well as a clinician or as a member of staff. And then what you're adding to there is that sort of empowering all staff to sort of be able to speak up and having sort of a flat hierarchy within our services to allow people to be able to approach, question and challenge sort of decisions or patients. And so we can be the patient's advocate, really. So, Anita, you've got your hand up. Lovely to see you. I'll unmute you and you can.
Hi, Chris. Thank you. Yeah, Suzy, as a non-doctor and a sort of junior ACP within the department at the time, I had a similar experience where I felt that my patient was deteriorating. It wasn't a chest injury; it was an abdominal pathology. However, I was in resus. I was with another reg, a really experienced reg who I work really well with, but she was at her absolute limit. And it was one of those cases where I felt something's not right. He's not getting any better with the treatment I'm trying to do. But I was just kept being told to no, we just carry on, keep doing fluids, keep monitoring, blah blah blah. And the patient wasn't getting any better, to the point where I suddenly thought, I need to speak up to somebody else. And it's really difficult when you're a junior member of staff and you're being told by someone senior to just carry on, it's fine. But I could see the patient wasn't getting any worse. And to make matters worse for this patient, he had learning disabilities, so he was non-verbal. So that the patient was even more complicated because he wasn't able to verbalise actually what was going on. So in the end, I did escalate to a consultant who was in charge of the department. I just said, look, I just need a second opinion. I'm not happy. Things are going wrong. He's not getting any better. And in fact, actually, I should have just trusted my gut instincts in the first place because it was the right thing to do. But as I said, I think from a junior clinician's point of view and as a non-doctor, it can be really difficult with dynamics with certain members of the team. Not that it's not that you don't respect them or respect their thinking or their decision making, but actually sometimes they're at their absolute limit, especially in the departments that we work in, are extremely busy, and with patients that you've just described, Suzy, running around naked, mental health, drugs, alcohol, our department's full of them a lot of the time, not always naked, but drunk and intoxicated. And they take up 95% of our time or our headspace. So it just can be really difficult. But I think that's one thing I've learned, actually. If something doesn't look right, doesn't feel right, it isn't right. And regardless of how you feel, you do have to just try and get another opinion, because otherwise it's going to go wrong.
Great. Thanks, Anita. I don't suppose you may want to answer this as well, Suzy, or others in the room. Does anyone have any ways that they will challenge that power dynamic we talked about? I don't know how much we alluded to there, but does anyone got any ways to remember it?
Sorry, Chris, ways to remember what?
So I suppose what I'm getting at is the CUS or the different acronyms we can use to sort of challenge things that may be going right, wrong. Yeah, so yes. I don't know if people are happy using those or which ones they use and if they wanted to share them.
It's when you ask and then you insist and then you tell and then you get them to stop. I can't remember the exact acronym, but in our Truro team, we're discussing how you speak up first to make a suggestion. And then if your suggestion's not heard, you emphasize it a bit more. And then you escalate it if you're still not being listened to. And then eventually, if you're still not being listened to, you just say, you just have to stop. Let everyone stop when you see a safety issue.
Right, and to be honest, I don't like acronyms, and I completely forgot what the acronym stands for as well. So that's how useful they are. But I have pulled it up, and the first one is concern. So you have a sentence with concern in it. The next one is I'm uncertain as to what you are trying to achieve with that. And then the next one is about safety. So if you think there's a patient safety issue, and then stop, as you mentioned there. So I think you are delivering on the acronym without having the acronym there, which is kind of what I would do as well. But there is acronyms out there to help facilitate that. Has anyone else got any other questions or comments around the case?
The only other comment that I have about things like that is I think from someone who's had a bit of imposter syndrome in their career, sometimes when you raise a concern and actually it's not validated because the person was right all along, you can think, oh, I shouldn't raise a concern again. But actually working in places where the culture is of being able to speak up about concerns is really valuable. And it means that when there is something that's not quite right with the team, that they feel that they can say something, that they will be heard, and they're not going to get shot down for it. So it's just that, like, sometimes when what you raise isn't validated, it can then put you off from speaking up the next time. But it's just being part of a team that welcomes that, and then it's always fine to speak up.
Yeah, Joy, thanks. I think it's real, that's why I guess these meetings are so valuable as well, because you hear like people's different experiences from different places they work. And I know that I've definitely worked, had experience of speaking out and being told, you're wrong. And it's really hard then to come back from that and say, but actually at the end of the day, as long as what you're trying, you're worried about the patient, I think, and if you're ever in that situation where you're worried about it with a senior, and going to them and saying, look, I'm just genuinely worried about this patient and I'm not sure if what we are doing is the right thing. And that's, I think, and then if somebody pulls you aside and says like, why did you go, like, I didn't tell you to do that, and why did you phone those people when I told you not to? You just be like, do you know what? I was genuinely just really worried about the patient. I'm sorry if I've offended you, but and just be really honest. And because it does happen, and you're right, I think we're getting better in the NHS at it. Well, I hope we are, but it still definitely happens, doesn't it? And so I think, but keep doing like what and patient safety at the end of the day is what you're worried about. So no, keep speaking up.
Yeah, so I agree with all those comments. I think the culture in departments is really important. That's why I love doing emergency medicine. I think we have a really good culture within emergency medicine to facilitate this. And at the end of the day, we are there for our patients, and we should be our patients' advocates and put our feelings and pride aside if we have those question marks with whatever we're trying to get across. In the conscious of time, we will run over late, so feel free if at 5 o'clock you need to get away. Technology and interest in debate have led us to this point, but if we can now move on to just sharing our spotlight for this month. So let's just see if that works. Can everyone see that okay? You'll see some nodding.
Yes, we can see it.
Great, thanks everyone. So every month, someone UK, Kenya, or elsewhere will put together a spotlight on, and it's a global health news bite. I'm not going to go through the details of this here, but I will share it on the group, and so you can have a read about what this month's topic is: period poverty. If you want to get involved in creating or sharing a spotlight on, or even presenting or speaking on the grand round, drop us a message on the WhatsApp, or you can email us on the email address that we'll put in the chat as well. So I'll leave it there. I'll stop sharing and I'll hand you over to Charlene, who will introduce the next speaker. Unfortunately, this will be a recording. It's around 8 minutes long. So not too long left, but I'll leave it to Charlene to introduce whilst I get set up.
Yes, so the lights are back on. So our power cut has terminated, which is good news. The next speaker will be Hannah. She's a clinical officer in Nyahururu. I do apologize for my pronunciation. I practice a lot, but I know I butcher it quite easily. Her and Josephine. Josephine was the nurse in charge in ED while the mass casualty happened. She unfortunately has some connecting issues, so I don't think she will be able to join either. And Hannah got put on nights spontaneously right now, so we recorded it yesterday. Maybe to just quickly paint the picture. So this was early hours in the morning during handover time when some of the morning team hasn't arrived yet. So they're very low staffed, and had a mass casualty come in. So Hannah will talk through a couple of patients, and it's just a couple of minutes. And I'll see if Josephine joins. If she does, then we can do a bit of a Q&A after. But if not, we'll probably have to leave it at that. So we're just going to go ahead and start the video.
Good evening, everyone. My name is Hannah Kinuthia, a registered clinical officer working at the Nyahururu County Referral Hospital at the outpatient department. I'm going to present a morbidity and mortality case of a road traffic accident that occurred on 26th of April last year along the Nyahururu Road. We were called as a casualty to help since it was a mass casualty. Next slide, please. The road traffic accident involved a 5-seater Toyota Fielder traveling from Isiolo to Kakamega for a dowry ceremony. They had left home, that is Isiolo, at around 5 a.m. in the morning, since it was a long journey. In the car were 8 family members, 4 children and 4 adults. The unexpected accident happened at around 8:30 a.m. at Leshau when the car lost control and landed in a ditch. The 8 passengers were brought in the emergency department by well-wishers and passers-by. Next slide, please. We're going to review the patients one by one. So patient number 1 was an 11-year-old class 5 girl who sustained 2 injuries, a cut wound on the chin and a right posterior hip dislocation. Upon arrival to the emergency department, she was in a lot of pain, and IM tramadol 100 milligram was given, tetanus toxoid, IV Placil 10 milligram stat, and was sedated with IV diazepam to allow for reduction of the posterior hip dislocation. Stitching of the cut wound at the chin was done. Chest X-ray, cervical spine X-ray were normal. She was admitted in the female ward and later on referred to North Kinangop Hospital, where plates were inserted for the hip injury, which got infected later on, but a second surgery for the same was done and was successful. She is now doing well. Next slide, please. Patient number 2 is a 3-year-old boy who sustained mild head injury. Upon arrival, his vital signs were normal and pain was managed. Chest X-ray, pelvic X-ray, lumbar sacral, and head CT scan were done, and they were all normal. He was admitted to the pediatric ward for observation. He was later on discharged and is doing well. He, however, complains of on and off headaches. Next slide. The third patient was a 35-year-old female who sustained an open book fracture of the pelvis. On arrival at the ED, her blood pressure was 89/59 and the pulse rate of 59 beats per minute. She was in excruciating pain. IV fluids were given and pain was managed with tramadol. Chest X-ray, pelvic X-ray, and lumbar sacral X-ray were done. The pelvis was immobilized with a pelvic binder, and she was referred to KU Teaching and Referral Hospital, where she was surgically managed and she is on follow-up. She, however, delivered a live male infant 1 month ago via cesarean section. They are both doing well. Next slide, please. The fourth patient was a 17-year-old girl who sustained a normal. Pain was managed, tetanus toxoid, spine X-ray, and pelvic X-ray were normal. She was discharged home with a diagnosis of soft tissue injury, post-RTA, and she's doing well. Next slide. The fifth patient was a 26-year-old female who sustained a right mild shaft fracture humerus and a cut wound of the forehead. Her vital signs were normal. Pain was managed, stitching done, and tetanus toxoid given. Chest X-ray, cervical spine X-ray, and pelvic X-ray were done and were normal. She was admitted in the female ward and later on referred to Isiolo. The hand healed and she is doing well. Other patient, please. So the patient number 6 is a 17-year-old female who sustained bilateral temporomandibular jaw dislocation, left neck of femur fracture, and mild head injury. Her BP at arrival was 133/83 millimeters of mercury with a pulse rate of 93 beats per minute, and the SpO2 at room air was 98. Pain was managed, reduction of the fracture was done. She was referred to Outspan Hospital for maxillofacial review and further management. She was operated for the same and is currently able to chew and talk, though not so much. She is on follow-up for the same. The next slide, please. So the other 2 patients unfortunately succumbed. Was a 50-year-old male who was a driver and who succumbed to the injuries few minutes after arrival to the ED. He had severe head injury and a suspected blunt chest injury. The other one was a 7-year-old girl who also succumbed on arrival. She had a right femur fracture and a suspected internal bleeding. They both were passengers at the front. Next slide. Thank you.
Right, perfect. Could I just ask you a couple of questions?
Okay.
So how many beds do you usually have in the ED?
Usually have stretcher.
3?
3 beds and 1 stretcher.
Okay, right. And do you know if the patients came all at the same time or did they come at different times?
They came at different times, but it was not ignorant.
I'm not sure if I heard any of the last part. Was that just my laptop or did it cut off for other people as well?
It was the same for myself as well.
It cut off for us.
Should we try that again? I'm not quite sure if I can answer on Hannah's behalf.
I think from the time perspective, it'd be good just to get people's feelings around sort of mass casualty presentations and anything that they feel that they can reflect on from that case or that sort of incident. Has anyone got anything they want to share?
Very well balanced diet.
We were just saying, the Truro gang was saying thank you to Hannah. I know she's not there in person for an excellent presentation. If we can pass that on to her. And just really an appreciation that 8 patients in one go anywhere would be huge. But someone already alluded to in the question how many beds or trolleys there are in the ED in Nyahururu, and there's 3 and 2 staff, a nurse and a doctor. and we'd all be quite overwhelmed by those injuries in a trauma unit or trauma centre here. So it sounds like they did incredibly well. It'd be interesting to know who they needed to pull in or who they could pull in to help manage all these cases seemingly so efficiently. It's very, very impressive.
And adding on to that, I think we all understand that these departments aren't empty departments waiting these patients. They are full of other patients who will need to be managed or moved somewhere. Anyone on the call who's able to give any reflection as to who would join the department in these sort of scenarios, both in the UK and in Kenya?
Maybe I can just quickly pitch in and about this mass casualty. So Hannah was actually one of the people that got pulled from ODP. So she's one of the people that works in the outpatient department usually and not in ED. But they had no doctor in the ED at that time when the mass casualty came in. So Josephine, who unfortunately struggles to hop onto the call, she was the nurse with 2 student nurses, and they were the only ones in the department at that time. So she sent people over to OPD, which is like a fast flow GP mixture, and got clinical officers from that side. And yeah, so they all came in at different times, but obviously they also mentioned when they presented the case that the lack of beds and physical space, and then also having the 2 bodies there was a big problem, because the other patients who were injured were family and friends asking about the passed away friends and family, and they could not put them into a more private area. So that was one of the big issues of that case that they had reflected on when they presented it to us.
Great, thanks, Charlene. Any other thoughts or comments?
Yeah, really good case to bring up there. Definitely food for thought for as a kind of trauma, major trauma centre here in the UK. That would, I'm just thinking how I'd manage that situation. So we would put out, that would get a paediatric trauma call and a adult trauma call, and probably that would almost be major incident. So we could probably call in a few more consultants, but I'm thinking body wise that those calls would probably generate roughly 15 extra people through our hospital bleep system for those cases, but possibly a few more, definitely if they were all coming in at once. So for you guys to manage that on those staff is, completely all credit to you. That's a very high injury load with severely injured patients, death in the car itself. So that's one of, if you have a death in vehicle, that automatically ups the level of trauma call that you would get at our hospital. So that would go from just that would generate, that's one of the key generators of a hospital trauma call, which for us gets a surgeon, gets an orthopedic surgeon, gets ITU. So just even one of those patients would generate a high level response. So well done to the team that managed that multiple casualty. And also I guess you've got all the, you've got a death of a child in there, so that it generates a lot of emotion within the staff as well. I don't know if there's if the team involved have any chance to debrief about that, whether they get a discussion on the day or a few days down the line about it, and whether you guys get that at all. I know we try, we don't always do it very well, but it's really hard, these cases, and especially when you've got a paediatric death there. So really good, great case to discuss. Thanks for sharing it.
Good
Sorry.
evening.
Yeah. We did.
Hello, good evening.
Hello, Paul. Do you want to say something?
Yes, I want to say something about how we handle mass casualty at Kenyatta National Hospital. First of all,
Yes.
we have to define what is a mass casualty. Once we have defined a mass casualty, which is a victims over 60, if we have a victim of over 60 patients, that is now what we call a mass casualty. Once we have that one, now we activate our disaster team. And then in disaster team, we have the incident commander and various team leads. So from there, we do have a pool of workforce whereby all the workforce that we need for that particular day are placed. And then these team leaders now will come and say to that pool and pick the people they want. Maybe they want nurses, doctors, whatever. Everybody's there. And then there we also do a mapping of flow of patients. We have those ones on criticals, those ones who are not critical. So they're placed in various places. And that is how now we handle our mass casualty. Most of the time in Kenyatta National Hospital, we do have this mass casualty. Like in 2-3 months, at least we have it once. Thank you.
Thank you very much.
Can I just ask one more question, Paul?
Yes, yes, you can ask me.
Do you practice these mass casualties, or because you mentioned that you do have them quite frequently, you're used to the protocol?
Yes, we do practice. Each and every time we do orient the team that is coming in, the new people, on what to do. Each and every time we have a mass casualty.
Thank you so much. That was very helpful. Any other questions or thoughts before we wrap up?
We just want to say thank you to Paul for his input as well. Sorry, we might have missed it in Truro, but what's your role, Paul? What's your job in the hospital at Nyahururu?
I am a senior medical officer working in accident and emergency at Kenyatta National Hospital. I'm one of the team leads there.
Great. So you're in Kenyatta. Yeah. Perfect. Okay.
Yes, I'm in Kenyatta National Hospital.
So people would get transferred to you from Nyahururu, would they? Or
yes.
For the trauma, if they can afford to go. Thank you.
Yes, thank you so much. Thank you to Suzy, especially for sharing this presentation. And I'll let Hannah know that we are all thanking her for that presentation as well. And thanks for your participation. Our next grand round will be on the 11th of December. If we could just, again, write our email addresses in the chat if we haven't done so, that'd be very helpful. And then we have a feedback form that we've just posted in the chat. And once you fill that out, a certificate of attendance will be sent to your email address. We also do have a WhatsApp group where we share the posters and keep everyone updated about our next grand rounds and the topics. So if you're not in it already, it's probably a good opportunity to join that one. So yeah, thank you so much, everyone, again. And we'll give a bit of time for everyone to click on the feedback form. And have a nice...
Charlotte, I just wanted to add as well that we've been recording these grand rounds over the last number of months, and there are 3 of the grand rounds from previous months on the YouTube channel. We will share that in the group, and to those who are not in the group, we'll email you the link to the group and also the link to the YouTube as well. So as Charlene was saying, thank you very much for joining us today, and we look forward to seeing you next month.
Hospitals, but people
Thank you, Chris. Thank you, Charlene. Charlene, where are you? Are you on the ground?
Yeah, I'm in Nanyuki.
You're in Nanyuki. Great.
Yeah.
And Anita, where are you? You're in Naniki as well.
Yeah, building on previous. Yes, like now like lots of different projects.
No, I wish I'm at home.
Oh, you're at home. I can see it looks a bit more cozy now.
Hopefully back to Meru next year, hopefully. Susie.
Great.